Imagine you've just survived cancer. I mean, you have crossed the ultimate finish line, right?
Yeah, it's this monumental victory.
Exactly. It's incredible. But then the dust settles and you realize that the very treatments that saved your life have fundamentally altered your anatomy.
Right. You're alive, but you're left with this highly complex medical puzzle to solve regarding your own body.
And that aftermath is exactly what we are focusing on for today's deep dive into the source material. We're unpacking a really specific, really challenging clinical question.
Right, the intersection of urogynecology and oncology.
Yeah, we're looking at what exactly is the medical protocol for treating structural laxity, specifically pelvic organ prolapse, or POP, when a patient is simultaneously dealing with radiation stenosis.
Which is a massive clinical challenge, by the way.
It really is. And to pull back the curtain on this, we're synthesizing a huge stack of medical literature today. We've got NHS consultation guides on specialized gynecology, the POGP clinical guidelines.
The pelvic physiotherapy guidelines, yeah?
Right, those. Plus detailed oncology care manuals, and even the latest NICE-E overviews on transvaginal laser therapies. So if you're listening to this and wondering how doctors balance competing biological disasters, you're absolutely in the right place.
Synthesizing these documents reveals just how profound this challenge is. You're essentially dealing with two completely opposing anatomical problems at the exact same time.
In the exact same location, too.
Exactly. And it requires a heavily sequenced approach, primarily because, well, standard medical reflexes are incredibly dangerous here.
Yeah, because the obvious medical reflex for a collapsing pelvic floor is to just, prop it up or stitch it back together.
Right, which you just can't do here.
But before we get into why applying that standard reflex to an irradiated pelvis creates a totally new set of dangers, we really need to understand the biological reality of what's happening. So let's look at the first player on the board. Structural laxity, or pelvic organ prolapse.
Right, so pelvic organ prolapse is fundamentally a failure of the pelvic floor's support network.
Like the muscles and ligaments.
Exactly. The levator antemuscles, the ligaments, the endopelvic fascia, they all work together to hold the pelvic organs, so your uterus, bladder, and rectum, in their proper positions.
Right.
But when that support system becomes weakened or damaged, those internal organs begin to herniate. They bulge down into the vaginal canal and, in severe cases, protrude entirely outside of the body.
Wow. So we have a scenario where the structural integrity is just compromised, things are too loose, gravity is winning, and the organs are falling.
Yes, that's the prolapse.
But then, directly complicating this, we have radiation stenosis. This is the collateral damage from pelvic radiotherapy, which, is a frontline defense against cervical or endometrial cancers.
Right. Radiotherapy is designed to induce lethal DNA damage in rapidly dividing cancer cells. But those high-energy beams inevitably pass through healthy tissue, too.
Right, they can't avoid it.
Exactly.
Right.
And in the vaginal canal, this triggers a condition known as obliterative endarteritis. The radiation actually damages the delicate inner lining of the microblood vessels.
Oh, wow, so they just stop working.
Pretty much. It causes them to inflame and eventually shut down entirely.
Which means the blood supply is severely compromised.
Yeah, that compromised blood supply means oxygen and nutrients just aren't reaching the tissue. You're dealing with cellular hypoxia.
Meaning low oxygen.
Right. And in this low oxygen, high stress environment, the body's fibroblasts, the cells responsible for forming connective tissue, they go into overdrive.
Trying to fix it.
Trying to fix it, yeah. But instead of producing healthy elastic tissue, they lay down rigid fibrotic scar tissue. Normal, stretchy mucosa is replaced by thick, unyielding collagen. So the canal narrows, it shortens, and it completely loses its elasticity.
And the oncology manuals emphasize that it isn't just rigid, right? The tissue becomes incredibly fragile.
Very fragile.
It loses its cellular turnover rate, becoming dry, thin, and prone to ulceration.
Okay, look, unpack this for a second. It's basically like trying to fix a tent where the canvas roof is collapsing in on you.
That's the prolapse. Right, the lack of structural support. But the entryway to get in and fix that tent has turned into this rigid, narrow concrete pipe.
That's the stenosis.
Exactly. Fixing one seems completely impossible without aggravating the other.
And to anchor your concrete pipe metaphor to the biology, we also have to look at the endocrine disruption.
The hormones.
Right. Pelvic radiation often targets or collaterally damages the ovarian follicles. So for a premenopausal woman, this permanently destroys ovarian function, throwing her into early induced menopause.
Oh, man. And that hormonal crash strips away the exact element estrogen that's responsible for keeping vaginal tissues plump and elastic.
Exactly. Estrogen is critical for maintaining the thickness of the vaginal epithelium
Yeah.
and producing glycogen, which feeds the healthy microbiome. You take away the estrogen, and you induce profound atrophy.
So it's a compounding cascade of trauma.
It really is. You have the physical scarring and microvascular death from the radiation beams, compounded by a sudden severe hormonal drop. The tissue is starved of oxygen, starved of estrogen, and fibrotic.
And because of this compounding trauma, the standard first-line treatments for prolapse just hit an immediate massive brick wall.
They do.
Normally, you'd immediately reach for vaginal pessary, right? Like a silicone or a plastic device inserted to mechanically prop up the sagging organs. It physically replaces the lost structural support.
Right, that's the standard go-to.
But applying that standard reflex here seems disastrous. I mean, if the tissue is essentially like fragile, dry parchment lacking a blood supply, wouldn't sticking a rigid ring into that environment just cause intense pain and more damage?
It would, and the POGP clinical guidelines throw a massive red flag here for that exact reason.
I figured.
Yeah, they explicitly state that a pessary is contraindicated, meaning it should absolutely not be used if the vaginal space is too narrow or too short to accommodate it.
Which is the defining characteristic of radiation stenosis.
Exactly. And even if a clinician can technically manage to maneuver a small pessary into the canal, the friction alone is terrible.
It seems like it would just tear the atrophic tissue apart.
It does. Friction in a hypoxic environment is highly destructive. The irradiated tissue lacks the vascularity to heal from even minor abrasions.
Right, because there's no blood flow.
Yeah, so a pessary rubbing against the vaginal wall can quickly lead to deep ulcerations, bleeding, and in severe cases, fistulas.
Wait, fistulas?
Yeah, abnormal connections forming between the vagina and the bladder or rectum. This is why the guidelines demand extreme caution.
Wow. So if mechanical devices cause ulceration and bleeding, the logical move seems to be forcing the tissue to heal biologically before introducing anything physical. Like the protocol must demand some sort of foundational rehabilitation first, right?
It absolutely mandates prioritizing the tissue foundation.
Yeah.
You cannot treat the structural laxity of the prolapse until you rehabilitate the local environment.
So what's the first step then?
The immediate priority is pre-pessary tissue conditioning. Clinicians typically introduce topical, localized estrogen directly to the vaginal mucosa.
Okay, but this raises an interesting dilemma. For cancer survivors, particularly those who battled hormone receptor-positive cancers, like certain endometrial or breast cancers, estrogen is often viewed as the enemy.
It is.
Introducing hormone therapy, even topically, must cause massive anxiety for both the patient and the oncologist.
Oh, definitely. The oncology care manuals spend a significant amount of time addressing this specific anxiety. But the distinction between systemic hormone replacement therapy and localized topical estrogen is really critical here.
How so?
Topical vaginal estrogen is designed to stay in the local tissue. It binds to the receptors in the vaginal canal to stimulate blood flow and cellular turnover
Sure.
with highly negligible absorption into the systemic bloodstream.
Oh, okay.
So many oncological boards actually deem it safe for cancer survivors.
But for those patients or oncologists who draw a hard line and just refuse any estrogen, regardless of systemic absorption rates, what's the alternative? I mean, they can't just be left with the concrete pipe.
No, of course not. In cases where estrogen is strictly contraindicated or refused, the protocol shifts to intensive, heavy, non-hormonal vaginal moisturizers and hyaluronic acid gels.
Okay, hyaluronic acid.
Right. It's a humectant. It draws massive amounts of water into the tissue, improving hydration and mechanical elasticity without interacting with hormone receptors at all.
That makes sense.
Yeah. The goal, whether hormonal or non-hormonal, is to plump and condition the tissue. You want to make it as resilient as possible over several weeks or months before a clinician even attempts to size a pessary.
So it's a strategic waiting game. You hydrate the tissue, rebuild the mucosal lining, and then eventually attempt to introduce a very small, soft pessary.
Exactly.
But let's look at the reality where conservative measures fail. Say the stenosis is too severe, the canal is completely obliterated, and a pessary either constantly falls out or causes immediate bleeding.
Right, it happens.
If conservative options hit this biological wall, the natural reflex is to consider cutting and repairing, right? Surgery. But looking at the manufacturer warnings and surgical guidelines in our sources, the surgical route looks less like a cure and more like walking into a minefield.
It's extremely risky. Reconstructive surgical solutions like a colpopexy aim to permanently pull the fallen organs back up and secure them.
Right.
Surgeons use either the patient's native tissue or synthetic mesh to create a supportive hammock.
Right.
But when a patient has a history of pelvic radiation, the biological realities we discussed earlier, specifically the lack of blood flow, they turn surgery into an extreme hazard.
Yeah, I was reviewing the manufacturer's own safety warnings for one of these synthetic meshes, a brand called Restorel.
Oh, yes.
They explicitly list pelvic radiation therapy as a specific condition where surgical risks must be heavily weighed.
Because anytime a surgeon makes an incision, the body requires a robust blood supply to deliver white blood cells, oxygen, and nutrients to heal the wound.
And we know radiated tissue doesn't have that.
Exactly. Irradiated tissue suffering from endarteritis simply cannot mount that healing response. So when you implant a foreign body, like a synthetic mesh, into tissue that cannot heal properly around it, the body's macrophages attempt to attack the mesh.
Which leads to chronic inflammation.
Yes.
And we aren't just talking about minor localized inflammation either. If you follow the NHS guidelines, they instituted a national pause on the use of vaginal mesh for prolapse entirely.
Right. That national pause was enacted because of severe complications, even in the general healthy population.
Wow.
Yeah, things like mesh erosion, where the synthetic material cuts directly through the vaginal wall, and extrusion, where it perforates adjacent organs like the bladder or the bowel. They're catastrophic complications.
So if healthy tissue sometimes rejects this mesh and fails to encapsulate it properly,
Yeah.
introducing it into an irradiated hypoxic pelvis seems like a guaranteed recipe for erosion.
It's highly likely.
Plus, there's another compounding variable: surgical interventions for prolapse, or even prior surgeries like a radical hysterectomy, which many of these oncology patients have already undergone, inherently alter the vaginal length.
Yes, every time you excise tissue or suture the vaginal apex to a pelvic ligament, you risk shortening the vaginal canal further.
Which means prolapse surgery risks exacerbating the exact anatomical problem that the radiation caused in the first place. You are trading a collapsing tent for an even shorter, more rigid concrete pipe.
It's a terrifying balance of risks, and this is the core focus of the NHS consultation guide. The guide emphatically dictates that this specific patient cohort, those with combined prolapse and radiation stenosis, cannot be treated by local surgeons engaged in occasional practice.
Right, so a general gynecologist who successfully performs 50 routine prolapse surgeries a year on non-irradiated patients is just not qualified to navigate obliterated tissue planes.
Exactly. The protocol mandates that these patients must be referred to centralized, specialized multidisciplinary teams, or MDTs.
Okay, MDTs.
Yeah, these are regional centers of excellence where complex cases are debated by a panel. You have urogynecologists, radiation oncologists, urologists, and colorectal surgeons simultaneously reviewing the imaging.
Because the organs are so close together.
Millimeters apart. And the connective tissue planes have been fused by radiation, so one wrong incision can lead to a bowel or bladder injury. Surgery here is the absolute last resort.
Only offered when quality of life is destroyed and all other modalities have failed.
Exactly.
So if a pessary is anatomically impossible to fit, and surgery is a high-risk gamble reserved for centralized MDTs, we're left with a massive gap in everyday patient care. I mean, the patient is still actively suffering from the prolapse and the stenosis.
Right.
Since mechanical and surgical fixes are fundamentally blocked by the radiation damage, the protocol relies entirely on active, long-term rehabilitation. It's about forcing the body to regenerate its own structural foundation using completely novel therapies.
And rehabilitation is really the unsung hero of this protocol. It is about rewiring the neuromuscular foundation and the cellular matrix from the ground up, which demands immense commitment from the patient.
Let's tackle the stenosis side first, the narrowing of the canal. The oncology guidelines highlight that the absolute cornerstone for managing radiation stenosis is the diligent use of vaginal dilators.
Yes, dilators are smooth, medical-grade silicone or plastic cylinders available in graduated sizes.
And what do they actually do?
The physiological goal of dilator therapy is mechanical stretching. By regularly inserting a dilator with a water-based lubricant, the patient applies gentle, sustained pressure against the vaginal walls.
Okay.
This mechanical force actively prevents the overactive fibroblasts from cross-linking and permanently fusing the walls together.
If you look at the protocols from the Leeds teaching hospitals, they outline a grueling timeline. I mean, this isn't a 2-week physical therapy stint. Patients must find their most comfortable size and maintain a strict regimen for up to 2 years post-radiotherapy.
Which is a massive physical and psychological commitment. The 2-year mark coincides with the period of maximum fibrotic activity following radiation exposure.
Wow.
Yeah, but maintaining that physical space is the only way to allow for crucial oncological follow-up exams, preserve the possibility of sexual intimacy, and keep the door open for a future pessary fitting.
So the dilators address the concrete pipe, fighting the fusion of the tissue, but we still have the collapsing tent. The pelvic floor muscles are weak, allowing the organs to herniate.
Right.
If internal physical therapy, like a physiotherapist, manually manipulating the muscles is excruciatingly painful due to the stenosis, how do we rebuild that muscular strength?
This is where we see a massive leap in medical technology. The Intimate Wellness Institute sources highlight the clinical application of high-intensity focused electromagnetic energy. It's commonly delivered through a device known as MCELA.
And the mechanics of MCELA are fascinating. The patient doesn't have to endure painful internal probes, right? They just sit fully closed on a specialized chair that generates a massive electromagnetic field.
That's right. That electromagnetic field penetrates the pelvic floor and directly depolarizes the motor neurons. It completely bypasses the central nervous system's voluntary control.
That is wild.
It is. When those motor neurons fire, they induce supramaximal muscle contractions, contractions that are far more intense and sustained than anything a human could achieve through voluntary Kegel exercises.
I saw the numbers in the literature, and they are staggering. A single 28-minute session on this chair delivers the physiological equivalent of 11,000 perfect supramaximal Kegels.
Which is just impossible to do on your own. By forcing the levator antemuscles to rapidly contract and release thousands of times, you induce cellular hypertrophy.
So the muscles get bigger and stronger?
Exactly. The muscle fibers thicken and strengthen, gradually rebuilding the structural hammock from the outside in. And you're completely avoiding the trauma of navigating the stenotic vaginal canal.
That's incredible. And we're seeing these highly advanced energy-based devices being deployed not just for the muscles, but for the mucosal tissue itself.
Yes, exactly.
The nice overviews detail a radical shift in tissue regeneration using transvaginal laser therapy, specifically fractional CO2 or erbium-YAG lasers.
Right. Fractional lasers operate on the principle of photothermal energy. The laser emits a highly focused wavelength of light that is absorbed by the water molecules within the vaginal tissue.
Okay.
This targeted energy vaporizes the water, creating highly controlled microscopic thermal injuries in the mucosa, while leaving the surrounding tissue completely intact.
It seems counterintuitive, though, to intentionally injure tissue that is already damaged by radiation. But this taps into the body's survival mechanisms, right?
Exactly. The microscopic thermal injuries trigger a massive cascade of heat shock proteins and growth factors. The body perceives a wound and rushes to heal it.
Oh, I see.
This initiates neocollagenesis, the production of brand new, flexible collagen fibers, and angiogenesis, which is the formation of new microblood vessels.
And the angiogenesis is the golden ticket. I mean, by forcing the body to build new blood vessels, you are actively reversing the hypoxia caused by the radiation. You're bringing oxygen back to the tissue.
Yes.
It's basically like taking the pelvic floor to a high-tech gym for a massive muscular workout with the electromagnetic chair, while simultaneously giving the cellular matrix a localized photothermal spa treatment to trick it into acting highly vascular and elastic again.
That's a great way to put it. The ability to regenerate functional tissue, restore blood flow, and rebuild muscle mass without relying on systemic hormones or highly dangerous surgical interventions is a true paradigm shift for oncology patients.
It has to be.
Yeah, and clinicians are also layering these energy treatments with direct injections of hyaluronic acid into the vaginal walls to immediately restore hydration, while the laser stimulates long-term cellular turnover.
So when you look at the entirety of the literature we've unpacked today, you realize this isn't just a checklist of treatments. It's a highly calibrated, sequenced dance. If you try to skip a step, the biology punishes you.
The sequencing is the entire foundation of the protocol. You cannot rush mechanical support. You certainly cannot rush surgery.
Right, you have to rehabilitate the local environment first. You deploy dilators to mechanically prevent tissue fusion. You utilize high-intensity focused electromagnetic energy to rebuild the muscular floor from the outside in.
Exactly.
You use transvaginal lasers and hyaluronic acid to force the regeneration of blood vessels and elastic collagen. And then only after months of this foundational prehab, when the tissue is robust and oxygenated, do you attempt the highly cautious introduction of a pessary.
And if, after all of that active rehabilitation and mechanical trial and error, the prolapse remains unmanageable and severely degrades the patient's quality of life, only that you present the case to a centralized, multidisciplinary team to weigh the profound risks of navigating irradiated tissue planes surgically.
It really is a masterclass in medical problem solving. It highlights the incredible, delicate interconnectedness of the human body. You target one variable, you eradicate a life-threatening cancer using radiotherapy, but in doing so, you fundamentally alter the biological landscape, obliterating blood vessels and altering hormones, making the repair of the subsequent structural prolapse exponentially harder.
He does.
Whether you're a medical professional, a patient actively navigating this exact sequence dance, or just someone endlessly fascinated by human biology, it completely reframes how we view medical intervention.
It demands an extraordinary amount of resilience from the patient, too, who must commit to years of daily rehabilitation. And it requires a deeply collaborative, restrained approach from the medical team, who must constantly fight the urge to offer a quick surgical fix.
Absolutely. Which leaves us with a final thought to ponder as we wrap up this deep dive. We are so heavily conditioned by society and by medical narratives to view surviving cancer as the absolute finish line of a journey. You ring the bell in the oncology ward and the story neatly concludes. But what if, for hundreds of thousands of women experiencing pelvic radiation, surviving the cancer is actually just the starting line? It's the chaotic beginning of a decades-long relationship with a permanently altered biological ecosystem, a body where the structural tent is collapsing and the doorway has been turned into a hypoxic concrete pipe. It forces us to ask a difficult question. As advanced medical science gets increasingly better at keeping us alive, how must we radically redefine what it actually means to be healed?